So my name is Michael Holberger. I'm the Professor of Dementia Research at the University of East Anglia, and I'm hosting this meeting. And I'm just sharing my screen now with you. So today we have Dr. Naoko Kishita, who's an associate professor at the School of Health Sciences here at UEA, and she works in dementia and complexity in later life. And she's going to talk to us about, can web-based acceptance and commitment therapy support family carers of people with dementia? And it's her findings and experiences from her IACT for Carers feasibility trial. Just some talk etiquette before we get started. So if you can, please keep your microphone switched off during the talk, and please keep your video switched off during the talk. Just makes it much easier for everyone. Now we have the question and answers. So ideally you use the chat in your meeting control bar to ask questions. So you can type in any kind of comments or suggestions or questions during the talk. We will go later through them, and then hopefully we can answer all the questions. But if you want to ask your question in person, then switch on your video, but keep your microphone off, and we will ask you to switch on your microphone to ask your question. And if your question was not answered or you want more information, then just please email us on this email address. Don't worry, we will put this email address as well later in the chat in case certain questions could not be answered. And without further ado, yeah, it's my great pleasure to introduce Nao, who is with us. So it's great to hear now your progress on this project, which I'm sure many people will be interested in what you have found so far. So over to you now.
Thank you very much. I'll just share my screen. I hope you can see my screen okay? The slide.
Yes, I can see it. Thank you.
Good. Okay, so thank you so much for giving me the opportunity to give this talk today. So I'm going to share our findings and experiences from our IACT for Care feasibility study. I'd like to start talking a little bit about why is this research so important. So before we applied for the grant application, before we applied for the grant, we conducted a series of systematic reviews, and these recent systematic reviews suggested that 1 in 3 family carers of people with dementia experience anxiety or depression, or both anxiety and depression. So from research evidence, it's very clear that family carers of people with dementia need psychological support. Unfortunately, many carers do not access timely psychological support due to various barriers, such as mobility issues or lack of respite care. So the family carers cannot leave their loved one with dementia at home and attend in-person psychological therapy sessions, or shortage of skilled therapists. So the combination of these different factors is currently leading to a long waiting list. So there are 2 important key challenges that we need to tackle: improved access and scalability. So improve access, so it's very clear from the research evidence that we need to improve access to psychological therapy among family carers of people with dementia. The second challenge is scalability. So we know that the number of people with dementia will increase, so that means that number of family carers will also increase. So we need a service that can be easily scaled up depending on the need of the population. So in order to tackle these key challenges, we need to design a service that can be delivered remotely with limited support from professionals, but also accessed at home at time chosen by the participant, the care. So the online psychotherapy has a strong potential to overcome these 2 key challenges. So what is the IACT for Care feasibility study? So we received funding from NIHR, National Institute for Health Research, to develop acceptance and commitment therapy for family carers of people with dementia, the IACT for Cares program, which can be delivered online in a self-help format with limited support from healthcare professionals. So this was a feasibility study, which is different from a large clinical trial, which aims to evaluate the efficacy of the intervention. So we had a clear 2 feasibility study research questions. So the first question was, is internet delivered self-help acceptance and commitment therapy for carers, IAC for carers, acceptable among family carers or people with dementia? And the second question was, is it feasible to deliver this new intervention within NHS services? So we wanted to test the feasibility and acceptability. So is it feasible to deliver this new intervention within formal healthcare services, and whether this is acceptable among the target population, the family carers of people with dementia? Now I'd like to talk a little bit about what is acceptance and commitment therapy and why we decided to use ACT as a main approach. So the core principle of acceptance commitment therapy is value-based living. Values are about deep down inside what is really important to us and what matters to us in our life. So this is just a brief diagram which explains the core principle of acceptance commitment therapy. So in our everyday life, we're always doing something. We talk, we plan, we work, we support each other, and all these activities or actions can be categorized into 2 groups. So the first category of actions or activity is the action that take us towards what we value, which is a box on the top right-hand side. So when we are engaged with these activities, we are acting more likely to be effectively, behaving like the person we want to be, and keep moving toward what matters to us in life. The second category of action is actions or behaviors that take us away from what we value. When we are engaged with these activities, we are likely to be acting ineffectively or behaving unlike the person we want to be, and moving away from what matters to us in life. Now, we always face a lot of challenging situations. So the box on the bottom. So for family carers, it could be managing the symptoms of dementia or coping with own health conditions, or sometimes you might have conflict with other family members. And these challenging situations naturally come together with difficult thoughts, emotion, memories, and sensations. They are almost inevitable. When we get hooked by these internal struggles, we are likely to be acting away toward. When we are hooked by these internal struggles, we are more likely to be taking behaviors that will take us away from what we value. But if we can learn to unhook or step back from these internal struggles, then we are more likely to be acting towards what we value. So the main aim of ACT is not about getting rid of these internal struggles, fighting with them, but learning to unhook or step back so that you can continue taking action towards what matters to you in your life, despite the presence of these internal struggles. Hope that was clear. Okay. Now I'll talk a little bit about evidence-based for acceptance commitment therapy. So as of August 2021, there are about 850 randomized clinical trials of ACT with various populations published worldwide. More specifically, recent randomized clinical trials demonstrated that face-to-face ACT delivered in person by qualified health clinical psychologists can reduce anxiety and depression among family carers or people with dementia. And also recent comprehensive systematic review demonstrated that ACT skills can be learned online. I also would like to talk a little bit about cultural competence in ACT. So when we think about diversity, so implementing the intervention to a diverse group of people, so the cultural competence in the approach that we use is very important. ACT has been implemented across many countries, including low middle income countries such as India and South Africa. And all this work that has been done in various countries has led to the development of Self-Help ACT for coping with adversity during the pandemic, and it has been available on the website of the World Health Organization in 11 different languages. And a recent large trial, a very large trial, which involved 868 people from ethnic minority groups, also demonstrated that smartphone-delivered self-help act was effective for smoking cessation. So ACT has a strong evidence base with various populations, and there's a good evidence that the ACT skills can be learned online, and also there's a good evidence on culture competence in ACT. So that's why we decided to use ACT, acceptance commitment therapy, as a main approach for our project. So the online program we developed is called iAct for Cares. It had 8 online sessions, and each session had 3 subsections: self-directed learning, reflection, and home practice. And self-directed learning section, this is where participants were able to log in whenever they have time and learn ACT skills on a self-learning basis, going through different audio recorded and video recorded exercise. And then reflection section is where participants are encouraged to leave questions or comment to their online therapist. And the online therapist provided feedback between the session. And home practice section is where the participants are encouraged to set a goal for the next week and practice some ACT skills between the session offline. So there's also optional 3 online peer support groups. So participants were able to join 3 online peer support groups while completing the online program. And this was completely optional. And also this option was only available if enough participants had signed up for this option. So online therapists, we recruited online therapists. So online therapists did not hold any formal qualification in clinical psychology or cognitive behavior therapy. They were mainly assistant psychologists recruited from NHS mental health services. So the therapists did not need to have any previous knowledge or experiences, but they were required to attend a 2-day training on ACT and online feedback provision for this specific study. And therapists were also invited to attend monthly drop-in group supervision sessions by video call during the trial. So if therapists had any concerns or facing challenges, they were just able to drop into group meetings on a monthly basis, and they were able to share concerns with other online therapists and learn from the other therapist experiences or receive support from the supervisor. So now I'm going to move on to the key findings. I'll start with the key findings on the feasibility of recruitment. So we had a predefined criteria for success. So when we apply for the grant, in the grant application, we specify that we will only come back to the funder and request a large funding to conduct a full-scale trial if we were able to meet these 2 targets in this feasibility study. So predefined criteria for progression from the feasibility study to a full-scale trial requires the intervention to be deemed acceptable to family carers as indicated by uptake, so recruitment of 30 eligible carers over 6 months, and initial engagement, so more than 70% completing at least 2 online sessions. So even if we were able to recruit 30 eligible carers over 6 months, if they all dropped out from the intervention after completing the first session, and if none of them came back, and I think it will be difficult for us to say that this intervention is likely to be acceptable, even with further refinements. So meeting these 2 targets in the feasibility study was really important. So these were the key targets for our current study. So number of participants referred and screened. So the recruitment took place between August 2020 and January 2021 during the COVID-19 pandemic. This was not something that we had planned, but it was just a timing that we received funding, but we decided to go ahead with the project rather than stopping the project. So during this 6 months recruitment period, we had 108 potential participants referred, which was more than we had expected. And of those 108, 79 participants attended the screening session. I would like to share some demographic information on for the participant who attended the screening session, because this information tells us what types of family carers might be interested in this type of intervention. So first, looking at the participants who attended the screening session by age groups, they were mainly in 50s, 60s, or 70s. And when we applied for the grant, one of the questions we received from the funder was whether all the family carers would be also interested in this type of intervention. And at that point, we didn't have a clear answer, but we now have some ideas. So we can say that those people who are in their 60s or 70s might be interested in this type of intervention, but not maybe those in 80s or 90s. But if we think about 10 years time from now, more internet user will become older. So I think now is the right time to start investing and start developing this type of intervention, the technology-based intervention. So majority of participants were female, and half of them are retired. So if you combine the number of those retired and those in part-time or unemployed, only 18% of them were in full-time job. Majority of participants were living with a care recipient, and they were mainly daughters and wives of the person with dementia. Looking at the participant by severity of anxiety and depression, so although we advertise this study as saying that this intervention is for those people who are currently experiencing low mood or worries, anxiety, about 30 to 40% of people who are not presenting any symptoms still did come and attend screening session. I think this is something very important to think about for the future project, because there's no harm for those people who are not presenting any symptoms to learn ACT skills to prepare for potential future crisis. But because of the study inclusion criteria we had set before we start the study, we had to exclude those people who are not presenting any symptoms for this feasibility study. But in the future project, I think it's really important to think about who we want to target and who might benefit from this type of intervention. Now, we also had to exclude those people who are presenting severe symptoms, because people who are presenting severe symptoms often require more intense one-to-one support, and internet delivers self-help intervention may be less intense for those people who are presenting severe symptoms. But again, those are people who are presenting severe symptoms may go and seek support, more intense support, like face-to-face psychological therapy sessions, but they could be potentially being on a waiting list for a long period of time. So again, there's no harm for those people to engage with this type of intervention while they're being on waiting list. So I think it's important to think about whether we want to also include those people presenting severe symptoms or those people who are not presenting any symptoms in a large-scale trial. So now I'm going to share the findings on feasibility of delivery and engagement. So after the screening session, 33 eligible participants were enrolled to the intervention, and 24% of them came from formal healthcare services. So they were referred from NHS or GP practice by the clinical team. Now, 76% of eligible participants came from the community, like self-referral, responding to the study advertisement. And I think these figures are very important, which suggests that there may be a family carers in the community isolated, currently not having a link to formal care service, healthcare services, or it could be lack of identification of family carers by the formal healthcare services. And again, this type of intervention has a potential to reach out to those people who are isolated in the community, but in a great need. So these 33 eligible participants were invited to 12-week intervention phase. So they were encouraged to complete all 8 online sessions in 12 weeks. 90 of them completed all 8 sessions during the intervention phase, so during this 12-week intervention phase. 5 participants, they stayed until the end of the 12-week intervention phase. So they didn't withdraw from the study, but they couldn't complete all 8 sessions. 9 participants decided to withdraw from the study during the intervention phase, so they were lost to the follow-up. Now looking at the participant by number of sessions completed. So majority of participants completed 7 sessions or all 8 sessions, which is a relatively high completion rate for this type of intervention. And average number of sessions completed was 6.24. And as I explained in the previous slide, 9 of the 33 participants were lost to follow-up. Now, dropout is always expected for any kind of psychological therapy, and it's normally between 20 to 30%, but it could be slightly higher if it's a self-help format. So I think the dropout rate for this project, this study, was also within the acceptable range. So those people who withdrew from the study, they gave us some reasons, such as that they were experiencing decline in the person with dementia's physical health, decline in own physical health, changes in caring responsibility due to COVID-19, or unfortunately the person with dementia or their close family member had passed away during the trial, and one person didn't provide reasons. So it was very clear why they had to withdraw, because they needed a different type of support. So in terms of the optional online peer support groups, of those 33 eligible participants enrolled to the intervention, 10 participants, 30% of them, signed up for peer support group option. 6 attended all 3 peer support group sessions, and 2 did not attend any. And so I'm also going to share some therapist data. So in total, 206 online sessions were completed by 33 participants. And on average, therapists provided online feedback for each session completed within 2.72 days, so about within 3 days. And this time gap ranged from 0 to 24 days, with majority, so 96% of responses provided within 7 days. So in majority of the cases, the therapists were able to provide feedback with between 3 to 7 days from the date they could receive the comments from their participants. Now, 24 days seems a quite significant delay, but these significant delays may occur during the Christmas holiday period because a lot of online therapists were on annual leave, which is very understandable. And on average, therapists spend about 20 minutes to write response to each session completed. And this length of time required ranged from 5 to 120 minutes, with the majority, 93% of responses written in less than 30 minutes. So you might remember that these online therapists attended a 2-day training for this specific project. And then after the training, they were able to draft the response feedback within 20-30 minutes, and then provide quick feedback within 3 to 7 days from the date they received the comments. Now I'm going to talk about acceptability of the intervention. So to assess the acceptability of the intervention, we conducted 2 qualitative interview studies. So we interviewed trial therapists, online therapists, and also we interviewed participants, family carers, or people with dementia who took part in the intervention. So now I'm going to talk about a qualitative study on therapist acceptability. So we interviewed 8 online therapists, and we identified 4 key themes from this interview. And we identified some facilitators and also challenges, barriers to the therapist acceptability of the intervention. The theme 1 was positive attitudes towards the intervention. So a lot of therapists viewed their involvement as an opportunity for their own personal growth, and they were also able to perceive some benefits to the family carers they were working with, and all these positive experiences led to the positive attitudes toward intervention among therapists. So it's facilitated a greater acceptability of the intervention among therapists. Now, theme 2 was therapist confidence to perform their role. So a lot of therapists highlighted that they appreciated the practical resources which they received during the training. And these practical resources, like example of feedback, led to immediate confidence after the training. But also therapists highlighted the continued practice and supervision and learning from other therapist experiences boosted confidence over time. So the opportunity for training and continued support was perceived as a positive experiences, and these led to the greater accessibility among the therapists. We also identify some barriers to therapist accessibility of the intervention. So theme 3 was connecting with family carers in a virtual context. So some therapists reported that they perceived challenges in the therapist care interaction because there are many interacting with their participants, their care using the text message. And also they didn't have much background information about the participant they're working with. Some therapists reported that it was quite challenging to develop a good therapeutic relationship in a virtual context. So they've suggested some ways to improve the therapist care interaction for the future project, like at least including like one-to-one phone call or video call at the start of the intervention, so that they can feel more connected with the care and have received some, find out more background of the person that they're working with. And theme 4 was therapist workload. So therapists, a lot of therapists highlighted that the workload was acceptable, and also user-friendly online platform was helpful, and also it facilitated their acceptability. But there's also time-consuming cases which increase therapist burden. So this relates to the theme 3, which is connecting with family carers in a virtual context. But because the therapist didn't have a lot of information about the person they're working with, it was challenging for them to generate a tailored feedback when their participants shared a very complex situation within the text message. And that took a lot of time for the therapist to carefully consider their feedback, but also a very short message from their participant, like just saying, oh, the session was great, or the session, everything was clear. All these short messages, so text message was also a challenge for therapists to tailor their feedback. So in the future trial, I think it's important to think about the ways to improve the therapist care interaction, but also maybe refining the training package for the therapist, and consider how we're going to address these challenging cases, potentially challenging cases, to reduce the therapist burden. So the next qualitative study was qualitative study on participant accessibility, and it was led by colleague Milena and Eileen. And we identified 4 themes, which includes both facilitators and barriers to the accessibility among the study participants. So theme 1 was usefulness and relevance of the content of the intervention. So many family carers expressed that the content was being relatable to their own experiences and needs, and they were able to find particular techniques that works. And self-compassion exercise was one of the highly appreciated exercise among others. Theme 2 was sense of connectedness. So although participants were completing the program at their own pace from home, they expressed that they were able to feel some sense of connection with other carers. So family carers was learning that, you know, how they're feeling was very normal, and they're all in the same boat. And that repetitive message they received from the program led to some sense of connection with other carers, or the virtual carers. And also a lot of participants reported that they received encouraged feedback from the therapist, and the connection with the therapist led to some sense of connectedness. Now, there are some ambivalent feelings repeatedly reported during the interview. So participants were appreciating the encouraged feedback from their therapist, but at the same time, that was led to the feeling of wishing to have more face-to-face contact with the therapist. So it was perceived as, the feedback from the therapist was perceived as positive, but also it led to some ambivalent feelings. Theme 3 was about the impact of the intervention on the participant. So participants reported some perceived benefits of the intervention. The most common one was saying that they were able to prioritize their own needs, and they were able to allow more to ask for help, or increase value-based activities like engaging in more exercise to keep their own health. And The theme 4 was acceptability of the online delivery. So there are a lot of positive attitude reported towards online delivery. The common comments received were that online delivery increased flexibility and it was very easy to access, and the program itself was not time consuming as they had thought. So overall, the online delivery was very perceived well, and it seems to be acceptable among family carers, but also some challenges that hindered participants' engagements were reported. For example, we had set a 1-week gap between the sessions, so participants were able to access the next session 1 week from the dates they completed the previous session, and that was a fixed date. And because participants are giving only 12 weeks to complete all 8 sessions, some participants expressed that they needed more flexibility within the program. So for the future trial, I think it's important to think about how we improve the interaction with the care and the therapist, but also to refine some of the programs so that they can have a bit more of flexibility and how they complete the program. So unfortunately, I don't have time to share all the quotes from the interviews. So I will just share key 4 quotes, which nicely summarize what this program was about. So the first participant saying that I thought I was just one who got so worried and frustrated. Basically, it taught me that everything I think and feel is quite normal. The second participant, so not be afraid of my feelings. I think I've learned that it's okay to just acknowledge those feelings are there, whereas previously I would have always tried to have fixed them or felt guilty for feeling that way. So I think that's helped me. The third quote, so I've definitely asked for help more from my family. I wasn't asking for help because they'd got such a lot on themselves, but I thought I must let them know that I needed help, even if they couldn't give me any. The last example, so I do a lot more exercise now. I'm able to go on walks. I was thinking about my parents all the time before and not necessarily thinking about anything to do with what makes me happy. I think the course allowed me to do that, and I'm still doing that. So this is just a summary of the presentation. So from the findings, I think we can say that it is feasible to recruit family carers into the trial, investigating internet delivery self-help acceptance commitment therapy for family carers. And it is feasible to deliver IF for carers by minimally trained novice therapists within NHS services. And also IF care seems to be acceptable among family carers and therapists. But further refinement may help improve acceptability, like including at least brief one-to-one phone call with the therapist at the start of the intervention. So the next plan, so there is now an urgent need for randomized control trial evidence on clinical and cost effectiveness of this new intervention. So we will use the data to apply for a large grant to conduct a full-scale effectiveness trial. So that's our next plan. And also I'd like to share some information on the publication. So the paper on the main feasibility trial has been accepted for publication recently. So it will become available online sometime soon, and it will be open access. So everyone can freely access the publication. And this paper includes a detailed session-by-session description. It's included in the appendix. So if you're healthcare professionals working with family carers, and if you're interested in the detailed description of the content, I hope these additional materials we are publishing will be very helpful. And also we hope to publish 2 qualitative studies separately, but they are currently under review. So I just have 2 more slides. So of course I couldn't do this project just by myself. So I'd like to thank all the IF for Care's research team, including public advisory members, Peter, Ruby, and Jeff. Thank you so much for your great support during the difficult times. And also I'd like to thank all the study participants who supported the study. And I also would like to thank all the clinical teams and trial therapists from NSFT, HVFT, and Octagon Medical Practice for their continued support, particularly during the COVID-19 pandemic. So thank you. Thank you very much.
Fantastic, excellent. Thank you so much. Now that's really, really excellent. So a good round of applause to you. Fantastic, really well done.
Thank you.
What an amazing, study, and I can see this can have, major impact, hopefully, on carers for people with dementia. So please feel free to type in your questions in the chat, or come on the video and you can ask your question in person. But maybe I get us started with some questions. I was really intrigued by what you said in terms of the, do you need anxiety and depression to benefit from this online program, or should this be a general kind of tool for everybody, caring for somebody with dementia? I just wondered, could you elaborate on that? Is that really feasible, or is it something you wanted to pursue?
Yes, I think from clinical perspective, it's important that we make it as open as possible and try to include everyone who are interested, because there's no harm for people who are not struggling at the moment to start learning new skills to prepare for future crisis. So for the future trial, I would like to be as inclusive as possible. But there's always a challenging from when you think about from research perspective, when you try to show the efficacy of the intervention, you need to target to certain people who has a high level of depression and anxiety. So there's an ambivalent feeling in myself, like, whether to think about more clinically or to think about more research importance. But I would like to be more inclusive in the future trial.
Yeah, absolutely. I can see that. That's the challenge, isn't it? For efficacy, you need to have a very, kind of strong outcome that you can show this. I think that's really fascinating. So Neda asked a question. It appears that participants were mostly women. In your experience, what would be required to help more men to engage with ACT for carers or any other similar programs for carers?
Well, it's hard to know, because unfortunately we didn't have many male carers, so we couldn't interview them and find out what motivated them to take part in the interview. But I think, well, one factor is that many family carers are female, so that's the representative of the population. But also I think we need to do a separate study and interview male carers to find out what might motivate them to kind of forward to take part in this type of intervention. So unfortunately, I don't have a clear answer, but I think that there needs to be a separate study to find out why there's a low uptake among male carers.
Yeah, but as you say, it might be more a generic problem, not a problem of the online aspect of the study. So Angela Doyle has, this was very interesting, and I can see how it would benefit many carers. However, I also know that so many of our service users do not have internet access. Is there any thought around being able to get financial support to get internet access installed in order for this to be offered?
Yes, that's a very good question, and that, of course, we only recruited people who have access to internet. So people who attended the intervention said that it was great and that it was acceptable, but we cannot ignore those people who doesn't have internet access. But the one thing we did was we tried to make it accessible. So this program is accessible from mobile phones, not just computer and laptops and tablets. So it can be easily accessed from mobile. So we did our best to make it accessible, but I think the challenge is I think it's hard to think about how we can target those people who do not have access to internet. The one way we could do is to try to create an app which can be accessed offline, but that's needs to be done as a separate project, I think.
Yes, I can just say that Erica Richmond has a follow-up comment. I wonder if Norfolk Library might be able to support the project because they have internet at their branches.
Yes, I think it's something that needs to be more collaborative with other organizations and further support.
And of course, there's then the issue of confidentiality to using something like this in a public space. But
Yes.
I can see that there's always the challenges. In the the old days, people would have said there's a clear selection bias, but hopefully, internet will become more and more common, and more people use it. But for some people, it might never be the right thing. I agree. So then Julieta Camino has a great question. Thank you for the presentation now, very interesting. How do you think the intervention could be delivered in future? As part of the NHS, charity-based, or would it be, which way do you see this could be delivered?
So we only tested the feasibility within the NHS services. So for now, based on our research findings, I can say that it is feasible to deliver within NHS services, particularly but it doesn't have to be secondary care services. So one of the research site was GP practice, and they were able to deliver the intervention. Their staff were able to provide feedback to study participants. So it can be delivered within both primary, like a GP practice, and secondary care services like mental health trust. But I'm also very interested to see whether we can deliver this type of intervention within social care services. I had a meeting with a group of people who work in the social care services, and they said that potentially their staff, like social care workers, could act as a therapist, online therapist. So I'm very open to the ideas, and I would like to see whether this could be implemented outside NHS for the future.
Great, yeah. And then Sam Richardson, thank you, this is very interesting. Can you let us know when it is published? I think that's the first question, which I think you have the publication. One is already published, isn't it?
Yes, I think it will be online in the next few weeks for sure.
So if you want to contact now directly, I'm sure she's very happy to share it with you once it's published. And do you think it would benefit family carers in general, or is it more specifically aimed for those caring for someone with dementia?
For our project, we tailored intervention for family carers of people with dementia. So the examples that we used were specific to family carers who are caring for a person with dementia. But if we could make it more generic, and I think, like as I've explained in the presentation, ACT has been validated with various populations. I think the family carers any family carers could benefit from the intervention, but we just need to tailor the content to make it more generic in that case.
I think that leads on, he has another question, if it would benefit family carers in general, or is it more specific, he's just thinking of those caring for family members who have other conditions too, maybe it could be adapted for those, and which you just answered, exactly. So it can be, that's the beauty of it, I guess, that it's so adaptable, isn't it?
Yes, it's very easy to change the content. So.
Then Pat Howell has a question. There was a proportion of mindfulness in the program, which I found profoundly irritating and a waste of time, until I simply skipped it every week. I realized I may have been in a minority in this study, but I feel it's only fair to warn future participants whose experience of this technique has not been helpful.
Yes, I understand. Some people prefer specific exercise, and some people don't, prefer a specific other type of technique. So what we try to do is to include a range of different exercise, audio and video recorded exercise, so that they can choose the one that they can feel that's most beneficial. So I think the continuous message we try to deliver within the program was that you don't have to feel that everything is helpful, but it's about having the toolbox. Like, you have all different tools in your toolbox, and you just pick the one that you find helpful at a time. So that was the whole idea. And I think to target, because if it was a one-to-one session, and then I think it can be tailored for the person's preference and needs, but because this was an untailored internet-based self-help format, I think the only way we can do is to be inclusive and include different type of exercise, so that the participant themselves can choose the one that they benefit most.
Yes, absolutely. I think that's a really great point, isn't it? Because it's this one size fits all. It's very difficult, isn't it?
Yes.
It's again, as a researcher, we like that approach, but for clinical purposes, that's not a good approach. So that's the dilemma always between that. And so feel free to type any other questions. I might have another question for you now. I just wondered, is there a minimal set of sessions that people need to do, or how did you come up with the 8 sessions? Or is this something one could adapt for how many sessions people actually need to do?
This is mainly based on the systematic review that we did. A lot of the psychological sessions are derived over between 8 to 10 sessions. So we decided to go with the 8 sessions. But I mean, if you want to make each session a bit more shorter and brief, obviously you could go for 10 or 12 sessions. But I think 8 sessions is quite standard for any type of psychological therapy.
Great. Julieta has another question. You may have said this, but is there any evidence in favor of ACT against traditional CBT approaches?
Can you say that again?
Sorry. Is there any evidence in favor of ACT against traditional CBT approaches?
Okay.
Cognitive behavioral therapy.
Yes.
Sorry, I should not talk in acronyms. Terrible.
So for the current evidence, if you look at the current evidence, the majority of the intervention that used for family carers is based on CBT, cognitive behavior therapy. And what they suggest that they are effective for treating depression, but not for anxiety. And when you look at the study which have used online and delivered a CBT, and that effect size even gets smaller. So CBT seems to be effective for treating depression among family carers when it's delivered in person, but not for anxiety or when it's delivered online. So I think there is a potential for ACT to be more effective, but we just need to find out by doing a larger scale efficacy trial. I don't know if that answers the question.
I think it does.
Yeah.
Would you sorry. Oh yeah, Julieta, come on.
Can I ask something about the CBT? Is also for someone to run CBT sessions, cognitive behavioral therapy, they need to be a psychologist, don't they?
If you need to be trained if you want to deliver like in-person face-to-face CBT, but there's a lot of online CBT which doesn't involve therapists.
Great. I think, would you compare in a trial, would you compare ACT and CBT with each other, or you're not planning to do that?
That's not my plan so far, but there is 2 randomized controlled trial study published by my colleague, which has compared an ACT and CBT, but they were delivered in person, face-to-face by highly qualified clinical psychologists.
And then I guess the question is, so you didn't talk, of course, if it actually changed anxiety or depression in terms of quantitative. Did you measure this as part of the feasibility? Yes,
so as part of our publication, which has been accepted recently, we conducted some efficacy, we analyzed some efficacy, but because this is feasibility, so main aim was not to kind of look into the efficacy in the group level. So we look at how people improved at individual level. And what we found was that more people improved on anxiety scale. So people improved with their anxiety symptoms, but not with depression, and which I found quite interesting because this is very opposite of CBT approach. So they seem to be effective more for depression, but not for anxiety. So I think ACT has more potential to target people who are experiencing high level anxiety among family carers of people with dementia.
That would be great because it would really be complementary then to cognitive behavior therapy potentially. Just a comment by Michaela Freeman. I just wanted to say that I still regularly use some of the techniques that I learned and they still really help me. I think that's a great feedback.
Thank you.
Fantastic. Do we have any other questions or comments? Feel free to come on or type your question. If not, Dan, could you put our email address in the chat again? That would be great. So if you have a question that might pop in your head and which you couldn't ask or comes on later to you, you can always ask us via the email address. And I'm not sure, I might have it as well. Let me just share my screen because I'll show you what as well is happening for the next meeting we're going to have. The challenge of technology. I'm struggling still myself. And just to say, so in the next meeting will be on the 18th of November at 2 p.m. And it will be on Care Self-Management Program Partner and Balance. This is a program used in the Netherlands quite a lot. And they're trying to adapt this for the UK. So there will be a presentation on what the plan is and what they have done so far. So it would be great if you could join us again. And there's our website again underneath it. So if you look at Dementia Research Collaborative at UEA, you can go to our website. And I hope to see many of you there again. But if there are no further questions, just to say thank you again to now. It was really great. Now I'm really pleased that it worked so well, and let's hope you get the funding for the for the big trial. That would be,
fingers crossed.
Yeah, fingers crossed. That would be amazing, you know. So well done again, and thank you all.
Thank you.